Good afternoon, and thank you for joining us for this WoundCon Innovation Theater. Wound care's best kept secret, an easy-to-use ECM is accessible to all wound professionals for use from day one. Sponsored by Aroa Biosurgery. My name is Alexis Paget, and I am the Senior Manager of Virtual Events for WoundCon. I want to thank you for participating in today's pre-conference webinar. Our speakers this afternoon are going to discuss the use of extracellular matrix products in the outpatient care setting. Before we get started, I want to review the tools in your session console. In the Resources app, found on the left of your screen, you'll find a list of downloadable resources provided by our sponsor. You can expand your slide area by clicking on the Maximize icon in the upper right-hand corner of the slide view. If you experience any technical difficulties, please click on the Help icon in the tray on the bottom of your screen. This should help to resolve common technical issues. To learn more about our speakers, you can select and expand the Bio app found on the right side of your screen. We'll conclude this afternoon's session with a question-and-answer segment, so please submit any questions using the Q&A app, also located in the right-hand side of your screen. We'll try to get through as many questions as we can. For any other comments or questions related to today's content, please use the Contact Us app to contact the sponsor directly. As a reminder, HMP Global does not give medical or reimbursement advice, nor do we provide medical or diagnostic services. The content of today's webinar is for informational purposes only. The views and opinions expressed in this webinar and contents are solely those of the presenters and do not represent the views of WoundSource, HMP Global, its affiliates, or subsidiary companies. Our disclaimer statement can be accessed in full in the Resources section of your console. I would now like to turn the floor over to Mike Linnell from Aroa Biosurgery, who will moderate today's session.
Good afternoon, ladies and gentlemen. My name is Mike Linnell. I'm the Global Brand Manager for Outpatient at Aroa Biosurgery, and I'm based in beautiful Auckland, New Zealand, where I'm actually a day ahead of most of all of you, as well as in the middle of winter, hence my attire today. It's my pleasure to moderate today's session, and it's certainly a privilege to introduce our speakers for this afternoon's piece, and that's Catherine Milne and Dr. Mark Moline. Both are well known to us, so I think really just a short introduction. So Cathy Milne is an advanced practice wound, ostomy and continence nurse, and she really practices across the continuum, so acute care, long-term care, home health and outpatient settings. And Dr. Moline is a surgeon and medical director of the mHealth Wound Healing Institute, and his medical interests are vast and include things like management of lymphedema in the wounded patient, adjunctive micronutrient application to wound care, wound pH biofilm, and emerging wound technologies. So certainly promises to be an exciting session. Cathy and Dr. Moline, thank you so much for joining us this afternoon. It's really appreciated. And Dr. Moline, may I ask you to begin today's session, sir? Over to you.
Mike, thank you for the kind introduction. And I just want to say, Cathy, thank you. It's just a privilege to present with you. And I want to thank HMP for allowing us to present today, as well as Aroa Biosurgery for allowing us to present the data. And I just want to say right away that one of the things that's always impressed me about Aroa and the team is, first of all, the professionalism, but also the depth of research and development to understand the mechanistic, the mechanism of action all the way down to the cellular level of why this product works. And I think as researchers and as clinicians, it's really important we always understand that mechanism of action. So as Mike said, from New Zealand come these beautiful sheep. And the story behind how this became a product of using ovine foregut, it was originally a part of the sheep that was simply thrown away during the processing. And so the beauty of it is reusing a otherwise disposed organ and then using the ontologic and teleological components of this that contribute to restorative and regenerative wound healing, as we'll show in the data. So as we look at the anatomy of a sheep, and it's obviously different than a human. So there's the forestomach and then the gastric stomach. They're completely different in terms of functionality, both for the animal, but also for us in chronic wound care. So what we really need for wound care is something that provides structure, architecture, and then facilitates restoration and wound closure by creating an environment that has all the right factors we need in chronic inflammation to get to more of a proliferative stage, and then brings in the right mix of components to help healing. So having 10 times of a growth factor or 100 times of another growth factor isn't necessarily what wounds need, because it might be the wrong amount. So the nice thing about using something that exists in a natural state is we're guaranteed of the right mixture. So again, there's abundant sourcing with the lambs that are raised down in New Zealand. The forestomach, importantly, is a very highly vascular organ. And the vascularization part we'll hit on again later on, but microvascular perfusion and the factors that are within the endothelial cells and within that extracellular matrix are very important for wound healing. And then the high rate of tissue turnover. So when a sheep eats whatever a sheep eats, it damages the inside of the stomach, meaning that the stomach has to be able to rapidly heal itself. And we're taking advantage of those properties to apply to a chronic wound environment then to help in terms of healing. So if you look at the natural state of the stomach before preservation into the product, you can see that they're very similar in terms of architecture. Now, of course, there's some changes as you go through the process of freeze dry, or also known as lipophilization, to terminally sterilize it so you're not passing on. There's no infectious component to this. But during that process, it decellularizes the extracellular matrix, however, leaves intact the architecture or the scaffold. That is, I think, a critical component in terms of why these types of products have such success. And then the extracellular matrix is being separated from additional tissue layers so that all we have is that superficial layer, because that's the layer that is the most functional. Now, when you look microscopically, and we're going to compare this to a reconstituted collagen versus the Aroa extracellular matrix, and you can see there's a definition to it. And there's an intact architecture that is already serving, again, as that scaffold to allow your body, or the patient's body, to be able to immediately have access to structure that allows proliferation. The amorphous component of reconstituted collagen is much less defined, and in peer-reviewed published data hasn't been shown to have the same outcomes. Within the Aroa ECM, there's greater than 150 different proteins, cytokines, chemokines, growth factors. Again, it's within that preserved nature of what it would be otherwise be within the sheep's stomach. And then the porosity and the structure is incredibly important, as again, we'll talk about here shortly. Within the ability to use this over exposed structures, such as this particular picture showing tendon, you can use it over types of these structures with good totality of wound care. So I always bring up the point in this situation of, I look at the wound edges, you can see there's edema here. So again, one of my forays is in terms of maximizing lymphedema or interstitial edema to maximize microvascular perfusion. So we're going to do all the typical things, whether it means a certified lymphedema therapist or other products that maximize compression to take care of that interstitial fluid. And of course, what's the nutrient standpoint? So bring in the registered dietitian. If there's vascular issues, bring in the vascular surgeon. And I think one of the most important things, and Aroa is so supportive of this, as Kathy has been educated on the same thing for many years, is collaborative care is real world care. So one product isolated by itself, if we want to see synergistic amplification of outcomes, it's bringing all the team together to work on these. So having that optimal balance of collaborative cares also then maximizes the optimal balance of the particular product that we're going to be using. Now, this term angioconjunction, you may not have heard of this before, but this is what facilitates that accelerated neovascularization, because with neovascularization is how you get oxygen and nutrient delivery, which typically occurs in 5-micron vessels, 5 microns being 1/3 the size of your hair. And ultimately, once you get neovascularization, much like when I do a skin graft, you get the imbibition and the anoscillation. So that's what's happening with microvascular perfusion within the first 24, 48 hours, because you really need that to secure the wound bed. And ultimately, you have to have that to supply the nutrients, the oxygen, to create functional tissue for that restorative complex. Now, this slide initially looks a little complex, but I'm going to break it down. Really, the message is all matrix technologies don't have the same qualities. So if you look at the square, where the best qualities would be in the upper right hand, kind of in that noon to 2 o'clock position if this were a clock. So what we're looking at is structure and biology. There are plenty of products that have a lot of structure. There's plenty of products that have a lot of biology. To get both structure and biology in the same product is rare. And that's where Myriad, which I use in the operating room, and Antimicrobial Endoform or other Endoform functions, because we've got both the functional biology with all of the retained extracellular matrix components with the cytokines, growth factors, etc., and we have the remained scaffold, or that architecture, that nano architecture. The combination is what is accelerating our wound healing and utilization. So again, this is the analogy here is like a chocolate bar. So if you have a chocolate bar that is intact, it's obviously that's the one you want to eat. If you got one that's melting, it becomes more amorphous, clearly changes the structure, changes the taste. So that's the analogy, is you're looking for structure versus an amorphous quality. This is the neovascularization point, and I think this is one of the really defining products of this component. And again, I applaud the researchers that have done so much work over the last couple decades on this product, because preserving these ghost vessels is incredibly difficult, and not everybody's been able to accomplish it. So the dye stain on the left-hand side is showing the retention of these microvascular channels. And the analogy is, think about a tree. We've all pulled up saplings before, and you see it's not just the initial roots, but it's those secondary, tertiary, quaternary branches. That's where all delivery occurs. So as blood flow is coming down these, it's going into those finest roots, and that's where oxygen nutrient delivery is occurring. So by the preservation of these structures within the ovine foregut that we're using in wound care, that's what allows this rapid angioinduction to occur. And again, that leads directly to nutrient and oxygen delivery. Now we're going to go through the next couple slides, and we're going to break down this diagram. So again, in the center, we're talking about greater than 150 extracellular matrix proteins. But if we break that down a little bit further, we're talking about structural proteins. So this is where all the diversity of collagens occurs, and laminin and elastin collagen is really what makes up that scaffolding again to help us. And you need all of them. It's just not one collagen or two collagens that's going to make the difference. And again, this gets back to how structurally this is what exists in the ovine foregut, but this is also exactly what occurs in our dermis and our epidermis in terms of helping to facilitate healing. The regulators of ECM, these are the coagulation factors, the protease inhibitors. So MMPs, or metallomatrix proteinases, when those levels rise in wounds, those are significant impediments to healing. So you need protease inhibitors to downregulate MMPs. And then we need factors that help in terms of the coagulation system, which goes into a subject of something called the glycocalyx with coagulation factors, inflammation factors, etc. So it's modulation of the wound of the inflammatory component, because inflammation is a significant detriment to chronic wound healing. It also then helps modulate the proteins and then assist with hemostasis. Obviously, we can take patients that are on any anticoagulant, whether it's a DOAC or whether it's Coumadin. We're always going to do some form of selective debridement when we're putting these on. But I have found that in the operating room as well as in clinic, this helps in terms of hemostasis, has been very facilitatory in that fashion. When we look at growth factors, fibroblast growth factor and platelet-derived growth factor, and then there's several different types of vascular endothelial growth factor. There's A, B, C. C is the one that really helps with lymphangiogenesis. But having all of these again in this milieu so that we have correct proportionality is what helps with overall signaling, so that you can bring in from the wound edges the remaining fibroblasts and remaining macrophages that help then to restore tissue. The basement membrane, again, this gets back to this very specific form of collagen, collagen type 4, and the perlicans and the laminins. Again, this all helps in terms of advancing the epithelial and endothelial tissues. And then the glycoproteins occur in two dominant areas. They occur within the extracellular matrix, but they're also part of the intravascular component, making up what's called the glycocalyx. So there's glycosaminoglycans, there's glycoproteins, there's proteoglycans, and all of this, again, helps in terms of restoration of that blood flow. one more simple analogy, if you're going to make a chocolate cake, you measure the components out very carefully if you want to make the best cake. This, again, is where when you look at Myriad, which I use in the operating room, when you look at Endoform, it is already pre-measured out, and it's what was successful for the animal when it was functioning as a foregut, and it's what's successful for us as we're treating our patients. So all soft tissue, if you just pick up a little piece of your skin and you look at the elasticity and you look at the resilience and you look at how your skin goes back to its natural state, that's because of the extracellular matrix and the cells that are within that to maintain those very important characteristics and quality. So within that soft tissue, we want both cells and extracellular matrix. Interesting about the Myriad and the Endoform is, again, it helps pull those cells into its predefined, highly structured architecture to help facilitate utilization of all those 150 different types of elements that we just talked about to maximize wound healing. So wound healing is, we've all taken the test, it's an incredibly complex symphony, and it's a complicated dance with certain partners coming in and out at certain times in the music. This is what allows, by setting up this natural component, to allow this to all happen in a synergistic manner. So we're providing a replacement extracellular matrix, and this has again been shown in data to be a critical part of the healing process, as shown again in research that we'll talk about here shortly. So again, there are many constituents in the tissue and maintenance repair. This is again breaking down the specific components and whether they're a structural class or whether it's an adhesion class, because you need both. You need structure, but once you get the structure, you need things to adhere together. That's what creates the durability for long-term outcomes. But I think the other thing that this really has a significant impact on is it helps decrease recidivism. So as we look at long-term outcomes, ideally we end up with a wound bed that goes on to complete epithelialization and closure, but also then has the resilience not to reopen in a short period of time. So this is a typical DFU case. Again, as I look at this, one of the big things we always want to control is the edema component. So if you look at the peri-wound margins, making sure you're using adequate compression, make sure you're dealing with, say, wound pH, make sure we're dealing with the micronutrients, that again would help facilitate. So you can see good wound bed prep on the side with good granulation tissue, no bone exposure, no tendon exposure, no undermining, little bit of peri-wound maceration, of course, that we want to address. And then as we're using the product, Myriad in this case, it's helping to down-regulate MMPs. It's helping to then decrease tissue inflammation, facilitate microvascularization with that angioconduction component, because there's already the preformed microvasculature within the product. That then calls in cells, so we get the extracellular matrix remodeling, and then we end up with good epithelialization. So in terms of publications, this is one of many publications that have come out recently. This retrospective real-world comparative effectiveness, so it was looking at ovine forestomach matrix, so again, Endoform, versus the amorphous collagen or the regenerated collagen in the treatment, specifically in this case of diabetic foot ulcerations. So this is data that came out of 449 wound care centers, looked at almost 26,000 patients. And if you look at the breakdown between the two, it's always about cohort matching. So you want to make sure you're comparing apples to apples between the two groups, and this is confirming that we are. And then as you look at the male component, female component, again, very well matched for age as well as for their hemoglobin A1C level, which of course we're going to keep track of in diabetics. Now, these are relatively smaller wounds, 2.0 centimeters for Endoform and 1.5 for the collagen product. And if we look at number of wounds per patient, they're exactly matched. And if we look at wound age, so chronicity is matched as well. Median time to closure in this particular study was 21% faster with the utilization of Endoform. And if we look at number of applications and visits to the wound care clinic, one of the things you'll notice about Endoform, and Kathy's going to touch on this later on, is it'll tend to essentially what we call melt into the wound. That's the downregulation of the MMP. So if you see it melting quicker, and then you'll get to a point where all of a sudden it pivots, and now the matrix stays around longer, and you're changing it maybe instead of once a day, you're changing it once every 2 to 3 days. And this, so it's just to compare apples and apples versus applying every single day with the collagen product. This demonstrates probability of healing, again, was increased by 38% with Endoform as compared to the collagen product. And again, outcome summary, 2,222 total DFUs were evaluated in that patient population. We saw up to 5.6 weeks faster closure time with using Endoform, and this resulted in a 38% increased probability of healing as compared to the collagen product. This was a poster that we presented at a meeting recently. This was looking specifically within the operating theater of using Myriad. For those of you that have not had a chance to see Myriad yet, you can either get it in 3 layers or 5 layers. I'm almost always, typically for the big wounds I'm dealing with in the operating room, using the 5 layer and then securing it on the wound. Kathy, with that, I'm going to pass it on to you, and I so look forward to your education, and thank you.
Thank you very much, Dr. Millen. And also, I want to thank HMP and Aroa for having both of us speak with you all today. Some of you are outside the United States, and a lot of you are inside the United States. And so some of the things that I'm going to talk about are particular to the U.S. healthcare system. I want to talk about my journey with Endoform today. Okay, I think my computer is being a little aggressive here. While I go back, I want to talk about what my practice is. I was introduced as practicing across the continuum. So what we do here is we find that we want to do advanced things in home care and long-term care and also in the clinic. And a lot of times we are faced with lots of barriers, right? And the biggest barrier I face in the U.S., and I'm sure most of you do, is the insurance approval denial process, especially for the cellular and tissue-based products. Because we want to use, we all love them, right? Because they work very, very well, and they really can close wounds faster. But there are certain problems when you look at the systems. Not only do you have insurance issues, you may have location issues. There are some third-party wound centers that won't allow you to put anything, a cellular or tissue-based product on anything other than a diabetic foot ulcer or a venous wound because they're afraid of a denial. If you send up one of these products to apply in, let's say, a long-term care facility, sometimes they get lost. And so that's a lot of money that nobody can find somewhere around that building. And then there are challenges in terms of staffing and staff skill when applying these products. So there are some pain points, although they work wonderfully. And it's very limiting because these barriers prevent us from really healing these wounds really well. So the question is that how do we overcome these barriers? Well, I actually saw this article from Dr. Ferreras, and he worked in the VA. And what he did was looking at his process, and it was very interesting. It's a great article. So if you ever have an opportunity to get a hold of it, please read it, because what he found is that there was non-standardization amongst the providers in treating the wounds. And there was a lot of cellular and tissue-based product use, which isn't necessarily bad, but it was very expensive for his clinic. So he actually established a protocol and an algorithm, and then he did a comparison of how the clinic actually, with a standardization and use of ovine forestomach, or also known as Endoform, in terms of improving the wound bed, so you could actually use less CTPs and then using actually reducing the cost. And when you see here in this article, you can see that they are still able to heal wounds extremely, really well. And actually, they were able to reduce their cellular and tissue-based products over a period of time. Now, I guess if I was a CTP company, I would be very concerned about this, but I don't think anybody should be really concerned. And the reason is because of the way we think about costs in the U.S. It really got me thinking about how can we get a product that actually can improve outcomes and reduce costs, because that's what we really want to do. And when we start looking at that hard to heal wound, this algorithm that a lot of us use is that we see the patient, we do this debridement, and we try to control the factors. Like Dr. Mellon said, you've got to control that edema and address that lymphedema. And then you kind of step back a little bit, and then you evaluate and decide where you need to go next. And then if they're doing well, you de-escalate your treatment and discharge them. And if they're not doing well and you have to wait 4 weeks, then you step it up and we'll use a cellular and tissue-based products, or a combination of that with other advanced therapies such as hyperbaric oxygen or negative pressure wound therapy. So there are a lot of combinations you can use. Now, the issue is when you so that's like the process, and the thought behind the process is this chart that everybody's pretty much aware of. It's called timers, and it really was started by a group of clinicians who wanted to give people who are new to wound care a framework of what to do. So we know that we have to address the tissue issue, and if it's devitalized, we have to get rid of it. If it's not red, it's dead, right? We have to address the inflammation and the infection, and Dr. Mellon talked about how these high levels of MMPs are rampant in the wound, and you have to address that. We have to make sure we have the right moisture balance, and we have to address those edges so we can actually get the cells to march over and reepithelialize that wound. And then, when you step things up, you can do that repair, and that's those higher level therapies that we can use, but are very usually unavailable to people in home health and long-term care and LTACs and assisted livings. And sometimes if you're not a wound provider, but maybe you're doing urgent care, you don't have access to this thing. So, and then we look at the social situation. We're spending a lot of time looking at social determinants of health in these wound care patients. I actually took this timers chart and added one more piece, and that is the system. Because if we don't manage the healthcare system that patient is in, then they're not going to get better, because we throw up barriers to prevent those people from healing all the time. And one of the barriers we have is that when we don't, not all of us can do the same things. That's the barrier. So Dr. Mellon and I are, have a scope of practice where we can put on a cellular and tissue-based product. If you are an LPN in a nursing home, you're not allowed to do that. If you're an RN in home care, you're not allowed to do that. So when you actually have strength in numbers, meaning as many people, whether you're an RN, an LPN, a PA, an NP, somebody with experience or no wound care experience, can all do the same thing that's beneficial for the patient, then they're going to get better faster. And so that's one of the things that we need to think about in the system, and how we can actually use extracellular matrices dressings to our advantage. And so I was working on a different project, and I came across this because I was comparing extracellular, cellular, and tissue-based products. And I came across this document that was really put out in 2012, which was 10 years ago. And that's when we called them skin substitutes. And when I was going down this list, I'm like, wow, Endoform is really a skin substitute, and it's never really been billed that way. And we've always kind of billed it as an extracellular matrix, and it's in the collagen category in the US. And it made me think that this is the barrier, is that, everybody can use this because it is in that collagen category. So we really can have strength in numbers. And, this is an unbiased report that really shows that it should be thought of as a cellular and tissue-based product. There is an elephant in the room, and this is more U.S. based, and that's because the elephant is we're going from a fee-for-service to a value-based healthcare system. And in this value-based healthcare system, providers and organizations are looked at in 4 different categories. Quality, i.e., how are the outcomes? How much is it costing? Improvement activities is, are you looking at what you're doing and measuring it and trying to improve what you're doing? And promoting operability, which is essentially going towards a more electronic medical record and more comprehensive across your systems and including your patients. So when you look at this in 2020, this was prior to the pandemic, the government said, well, we will give you, we're going to pay you based on these things. And, 45% of that payment is based on quality, and, and it goes all the way up to at least 15% cost. Now, if you do really well on this scoring sheet, you can get up to 9% extra for your fee-for-service visit. And if you don't do so well, you get minus 9% because it has to be budget neutral, according to Congress. Now, when you think about how are you going to be scored, let's look at how they're changing these ratios. So in 2017, the system cared about quality. In 2022, we're not so much care about quality, but look what we're thinking about cost. So 30% of what you're being graded on is cost. So if you're using a lot of advanced therapies, you might be healing your patient, and 30% of that is your quality. But now you might be getting dinged on cost. Will you ever get away from using cellular and tissue-based products like the amnion, chorion, and things like that? No, you'll never get away from them. But if you prepare that wound bed well, you may be able to use less. And Dr. Ferreras has been essentially shown that in his paper. So, and I would have stayed with this chart until about a month ago, when the government said, hey, we have a pandemic, so this year we're not going to look at cost. So this year we're saved. But I think that's a good thing, because now we can start looking at our practice and thinking about what we are spending, and then let's see how we can improve both our quality, and because that 30% will be shifting back to 60% of quality while they're taking away the cost. And so we can prepare for the future now and starting to get really comfortable and initiate those systems that will support that. Now, Endoform, you get a lot of questions, and people think, well, I have to wait 30 days. Well, you don't, because it's available for all wound professionals and non-wound professionals. So if you have been asked to put on a dressing, you can put on Endoform because it is available. It's considered a collagen in the U.S. system. And you can see when you look at this chart how the technology and all the cellular and structural components are there, and they're the same as the things that you see in the cellular and tissue-based products. And that technology assessment, that picture that I showed earlier, supports that. And what Dr. Mellon had talked about also gives us that idea of that physiology of how all that works. So the nice thing is anybody can get this. And the question is that, so people think, well, I have to have my patient in a wound center. And actually, you really don't, because it is available to all people in all settings. And you can do it from day one. So the advantages is that you don't need a lot of training. It's putting on a dressing like you would any other. You can get it, and it's easy to obtain and cost effective. If you feel that you need an antimicrobial for your patient, there's one form that has silver in it. And if you have a little bit more drainage, you're afraid, I don't want to use it because it's going to float off it's not going to stick to my wound, you can actually get fenestrated and high flow versions. And because, and as Dr. Mellon had talked about how it reduces those inflammatory matrix metalloproteases, you can use this. Maybe you still are going to use a cellular tissue-based product, but you can use this to prepare your wound bed really well. Maybe you'll do such a good job you won't have to, but you are going to help your patient down the road as they need any type of other type of advanced therapies. Time is tissue. You cannot wait for those magical 30 days that have been imposed upon us by our regulatory guidance people and our insurance people saying, oh, you have to wait 30 days. What we don't know, but in my experience, is that I do think we're seeing improved cosmesis. I think our patients are moving from, I'm glad you've healed my wound, to, I really wish I didn't have a scar, because they expect their wound to be healed these days. And I think we have to really start thinking about, yes, we have one paper from Dr. Ferrer's, but I think we need a lot more of work in this area to say, that's one experience and maybe there's more. And maybe we can use these combinations to actually reduce our costs and improve our quality. And then we haven't really looked at the post-acute and settings very well, specifically home health and skilled nursing facilities, because people don't know that it's available to them. So we have very, very little to go on there. And I think we need some work in that area. So just as I kind of mentioned before, Endoform is this natural restorative bioscaffold. And again, you don't need to wait 30 days before you can place it on a patient. The other thing is that you have an antimicrobial, and that antimicrobial is silver. And they have done some great work in terms of cytotoxicity, and there's no cytotoxicity to dermal cells. The other interesting thing is that, not all silvers are alike, and that's, again, like a whole nother lecture. But you really want something that is going to prevent biofilm formation. And so this actually has the data to do that. Now, when you think about what kind of bugs might be in your wound, here's the data on that. It is effective against MRSA and VRE. And of course, we have our usual suspects, our Pseudomonas and our other yeasts and molds. And people don't really appreciate yeast and molds in the wound, but they are there. And if we did more PCR testing, I think we would be more attuned to this, but it does take care of those too. So that's a nice added benefit. I talked a little bit about that non-cytotoxicity. And again, here's the data on that. And again, it is sustained. So you can leave this in the wound for up to 7 days. That's how long we have for the data. You may not need to or want to, and that's a whole nother story I'm going to talk about shortly. So where can you use this? You can use this on pretty much anything. So remember, a lot of places of employment may restrict you from using cellular and tissue-based products just to venous wounds or diabetic foot wounds. This can be used on any partial thickness wound, full thickness wound, surgical wounds, as well as our ones that we are very commonly see, including venous and diabetic wounds, but pressure injuries. And we can put it in tunneled wounds, and we can put it in wounds that have undermining, and surgical wounds and traumatic wounds and draining wounds. So really, it has great clinical utility because you can use it pretty much anywhere. And the nice thing is that you can use this in patients who are having hyperbaric therapy under compression. If you're offloading a patient, you can put it on the wound and put their total contact cast on or their crow boot, whatever you're using. And you can use it under negative pressure wound therapy. You would want to check your manufacturer's product insert to see if that would be an approved indication. Now, let's talk about the real world stuff, right? So the clinical application, prepare the wound bed. You would do this whether or not you are using a cellular or tissue-based product, whether you're using a calcium alginate, whether you're using gelling fiber, you got to prepare the wound bed, which means cleansing it, trying to, doing good wound hygiene in the wound bed, around the wound bed. If it needs debridement, you would be debriding that wound, whether it's a curette, a pulse lavage, whatever you have, and that's in your scope of practice. Then you apply the the endoform and cover it with an appropriate secondary dressing and then secure it. And then you reapply it as needed. So the question is, what is as needed? I'm getting a little ahead here. So the ahead, how often is when you see what we call the visual residual. Here's a case of mine. He's 46 years old. He came in with sepsis. He had a sacral deep tissue injury, which eventually became unstageable when you see here. He was being treated with chemo for mantle cell lymphoma and non-Hodgkin's lymphoma. He was also a paraplegic, neutropenic, anemic. He needed a stem cell transplant. He was thin as a rail. He was depleted protein-wise, and he had multiple UTIs. You know, we would joke with him half-heartedly that if he didn't have bad luck, he would have no luck at all. And he would say that a lot. And he developed osteomyelitis in the sacrum. He had many admissions for pancytopenia. It was during the pandemic. So some of the care that we normally would have given him, like put him in an LTAC or a short-term rehab, wasn't going to work for him because of the pandemic and the high rates that we were having at that point. We did do negative pressure wound therapy. We gave him protein supplements, offloading. We gave him intermittent granulocyte colony stimulating factor, antivirals, antifungals. Everything we could for this man. And many times we asked the insurance company, look, we need to have cellular tissue therapy. This man needs a stem cell transplant. He's going to die without it. If we don't do this and get this wound closed, he won't be able to get that done. So day 45 after negative pressure, we really haven't budged a whole lot here. And then when you take a look, we ended up placing Endoform under the negative pressure wound therapy at day 120. So that wound hadn't really budged at all. And so by week 2, you can already see the tremendous improvement in this wound. And by week 11, we were closed and he was able to go off for his stem cell transplant. So it was great. This is a case of Dr. Greg Bone, and I want to thank Dr. Bone for sharing this with us. Wagner grade 3 wound, osteomyelitis, and you can see that it's a very complex wound on the next page because they ended up putting the endoform into strips and placing it all the way through. And you can see this is a nasty wound, and it actually went on to heal. And so did really, really nicely. So you can be a little, I want to say, creative, because none of our chronic wounds are easy, right? So you may have to roll it up and place it all the way through. So I talked about the visual residual. So what is residual endoform? So if you have applied endoform, you might see it on the wound. So we call it the visual residual. And it really tells you a lot. Your wound is actually speaking to you. And it tells you really what I need. And so these are examples of what you would see. So the question is should you expect to see it? And how do I know it's residual? And do I debride it or do I leave it there? And so how much do I apply to the wound, and when do I not? So usually we start with 2 layers of endoform, because remember, this endoform will actually act as a sacrificial substrate for those high levels of matrix metalloproteases. So if you have 2 layers, it may eat that 1 layer, and as it reduces those inflammatory chemicals in that wound bed. So we usually leave it in for 3 to 7 days. I usually check in at day 3. So it's great for home care, Monday, Wednesday, Friday. And then, here's this little algorithm. If it's healed, then you don't need to do it. If it's not healed, so then how much, really you're saying, how much is left in that wound bed? So then what we end up doing is looking at irrigating it. And because some of this may be actually a buildup of fibrin or exudate. So you want to irrigate your wound just gently. If you feel like it needs to be debrided, you can, but you don't have to. Maybe a quick wipe is good, because if it's residual and it's staying there, it's going to be adhered to that wound bed. So if you have no residual, you have high MMP levels, your wound is clean, you've got to put this on a clean wound. You have to make sure there's no dead stuff there. And so you're going to put, up to 4 layers. You can use 2 if you've started with 2, but you can double it. And I would consider doing it. And if you have moderate amounts of visual residual, again, irrigate it, debridement if it's indicated. You could cross-hatch it if you're really not sure, is that, non-viable tissue or is that endoform? And then just reapply the same numbers. So you can see the difference between the heavy or the no residual and the moderate residual. Now, this is what high residual looks like. And this is where people just want to, if you don't know what high residual endoform looks like, you're going to want to debride this. So you really have to say, nope, I'm not going to do that. I'm just going to gently irrigate it. I might want to wipe my wound off, maybe with a device that is suited for that, or maybe a non-woven gauze, and then you reapply your endoform. This means you're building tissue and your protease levels are low. So your wound is speaking to you. And that's how you know things are going really well. So again, no residual, moderate residual, high residual, and they look very, very different. We put this in our handouts. So I want to think about, again, as we summarize here, there is value and value. And when you're using an extracellular matrix such as Endoform alone, or using it to prepare the wound bed before you're using a cellular and tissue-based product, you're going to reduce your costs. You've improved your wound bed preparation. And when you can do this across all settings, wherever that patient is, and anybody can do this, strength in numbers, then you're going to lower your own costs. You are going to have efficiencies in your workflows, and as this patient transverses across that continuum, and you will be able to, when you do have to move to a cellular tissue-based product, you can speak reasonably to somebody who's trying to deny you. And you'll be better prepared for bundle payments as they come along. And as your outcomes improve, it will reflect in your quality numbers. I am going to actually hand this now back over to Mike. And thank you again for having both of us. We enjoy spreading the word here, and we're willing to take questions.
Thank you very much sincerely for an excellent presentation to both of you. We're going to begin our Q&A session now with Dr. Malene and Kathy. As a reminder to the audience, please, you can submit your questions using the Q&A app, and obviously we'll try to get through as many questions as possible before the top of the hour, so looking forward to that. There are a number of messages that have come through already, and I think maybe if I just start off with the first one that's come through here. Dr. Malene, occasionally I've got questions from patients about religious or cultural acceptance for products I'm using. Any concerns here?
Well, I think the first thing to do is just be open and transparent. It's sourced from a sheep. If within their faith there is a concern about a sheep-based, then I think we have to be incredibly respectful of that, and I would always err on the side of caution when it comes to discussions of faith. So I think it's an excellent question. Obviously, there are products out there that are porcine based, and I know there are bodies of faith where clearly porcine would be not an option. But I think it's just important to be respectful of the conversation.
And may I add on to that? I think when we think of faith, we think of religion, but we have people who are vegans and don't want to use any animal products too. So getting to know your patient holistically can be very helpful in these situations.
That is such an excellent point, Kathy. Thank you for saying that.
Absolutely. Perfect. Thank you. All right. The next one, the comment here is, this has challenged me to use it more widely. Where would you not use it? So where would you not use Endoform?
Well, I'll start. Although people have used it on exposed bone, I have to tell you, I have not had that experience. But I can't think of any place that I probably wouldn't. How about you, Dr. Mellon?
In clinic, I would not put it on exposed bone because I don't have the ability to really decorticate that bone. But in the operating room, I'll use a burr. And I have used Myriad, which is the 5 fused pieces together on top of exposed bone. Sometimes I have to do a reapplication, but in that situation with really good wound bed prep, I have done it on bone, but that, again, that's a surgical component. So I would be very cautious about putting it on top of bone in the clinic where you really can't get rid of that totality of cortical biofilm that we deal with.
Absolutely. Absolutely. Perfect. Thank you very much. The next question is, how early in the treatment process is it appropriate to begin treatment with Endoform?
I start as soon as my wound is clean.
If you think about, again, and Kathy had called that out as well, the MMP quenching component of this device, it's like a mop to soak up MMP. So if those MMPs are drawn up and then basically extinguished, you're decreasing inflammation. And so I think using it early on, again, this is where, and Kathy showed those great cases where it's going to degenerate quicker with higher MMP levels. And one way to know that you've tipped the balance is it doesn't degenerate within the wound. Now you know that your MMP balance is really well managed. So I agree, Kathy. It's like start earlier. It's not like a card you're waiting to play in poker where you're waiting for the right hand. It can be used from the get-go.
I love that analogy. That's a very good one.
Excellent. Wonderful. This is a question that's been passed through. I assume that this is one of our international guests. Is this product available worldwide?
I
can't answer that because...
Mike, would you like me to...
Yeah, I was just going to say, would you like me to take it? Yes, the short answer is it is definitely available around the world. We registered in around 30 countries around the world. So the best thing that I would suggest you do is contact your local representative or distributor to find out if they are stocking it for you. Alternatively, you can also obviously send us an email and we'll be able to get back to you with where you can source your Endoform from. Great. Lots of questions here about access. So what is the cost difference for the antimicrobial version?
I think it would depend on your organizational's contract. I'm not seeing any difference where I'm using this.
Same here. We see no difference between antimicrobial versus natural product.
Absolutely, I concur. There's no cost differential between the natural and antimicrobial, and that was part of the original sort of pricing decision from the founder. He wanted to unlock that regenerative healing for everybody, so he decided to make this advanced product available to everyone, and obviously not put a cost differential between the natural and the antimicrobial, and there's no cost differential between the different fenestrated formats either. Perfect. I think we've got time for one last question, and that would be, is there an age limit to when you can start using this?
So well, I don't... Go ahead.
Well, go ahead, please. I was just going to say, in our clinic, because I can't pediatric patients, we're limited to age 18 and above, and I've put this on from patients 18 years old all the way up to 100 years old.
And I'm also limited by scope of practice, so I can only see patients 18 and over. It's my understanding that there is no age limit, however, but I cannot see patients under the age of 18.
I think in the under age 18, especially if we have an epidermolysis bullosa clinic, right? And so I would love to do more work with those younger patients, but those are very select niche group of people where there's no research. So when we start talking about younger folks, I think we got to make sure we're talking about what diagnosis.
Fair enough. Perfect. Well, thank you very much. Sadly, I think that's all the time that we have for questions. So I just want to extend a warm thank you very much, Dr. Melina and Kathy, for this wonderful presentation and discussion. I've really enjoyed that. And for those of you with additional questions about today's program, you can contact Aroa Biosurgery directly by submitting an email through to us, or you can contact us via our website. And we'd also love to have your feedback on this webinar. So please, I'd like to encourage you to open the survey widget on your consoles and complete a few quick questions. And in fact, the last question allows you to ask anything that you would like, as well as request a sample or an Endoform in service, etc. And you can leave your contact details there. Again, my thanks to both speakers, and I'm going to hand back now to Alexis, who's got some further reminders. And thank you very much to everybody watching around the world, and kia ora. Take care.
Thank you, Mike. And thank you to Dr. Melina and Kathy for this presentation. If you have not already registered for WoundCon, we invite you to do so now. WoundCon is completely free for licensed healthcare professionals and provides you with the opportunity to earn free CME credits. Thank you for all of your time and attention this afternoon, and I'll see you at WoundCon.